bit Meraki. Una de honey, honey. Baby, you know about it. Yeah. Se la que hay, pues la que hay. Yeah. Y Peter Sonner, that's my kind.
So now you will be happy to see that you have covered from here all the way you are at this point. Let us move over to the next schemes, that is the Suman scheme, PMSMA. So the demarcation between the previous schemes and this schemes is that these are mostly launched after year 2019 onwards. So relatively you can say that the current schemes that I will be discussing, these are the relatively newer schemes. So talking about the first one, the biggest one, that is the Suman scheme. What is Suman? Suman stands for Surakshit Matritva Ashvasan. Suman stands for Surakshit Matritva Ashvasan. What does Surakshit mean? Safe. Matritva is motherhood. Ashvasan means a promise, a trust, a guarantee. So in Suman, basically we in the government of India, we are taking guarantee that there will be a good delivery service, there will be a good mother care and a good neonatal care. So these are the elements that the main focus is about the guarantee. The main focus is about the trust. It is about Ashvasan. It's not a Surakshit Matritva Abhiyan. It's not a Surakshit Matritva Yojana or a Karyagram. It's a Surakshit Matritva Ashvasan or a guarantee. That is what is Suman scheme. So what are the elements in Suman scheme? The elements are something, it's like a big daddy of the JSSK. Just imagine it this way. It's a bigger version of the JSSK, that is Janani Shishu Suraksha Karyagram. You remember it in the previous module. So we are going to talk about the free ANCs, free deliveries, free postnatal care, free treatment, free transport, and the hallmark of this is no tolerance to denial. So under the Suman scheme, no private hospital or maternity care clinic or doctor can deny services to a pregnant female. It will ensure, listen to the words, that's all. It will ensure respectful care, care with dignity. It will ensure respectful, whatever I am highlighting, beta, these are the MCQs. It will ensure respectful care with privacy and dignity, with early initiation and support for breastfeeding, zero dose vaccination, free and zero expenses for sick newborns and neonates. Please make sure that you know that it is it's a trust, it's a guarantee that we will have to give you care to all the pregnant females, mothers and sick neonates and children with care and with dignity. That is what is Suman scheme. So what are the components? You can remember these are the 6 components. There will be ambulance services, same 102, 108 ambulance services, minimum 4 ANC visits. You remember less than 12 weeks, 14, 26, 28 till 34 and 34, 36 and 36 till term. Delivery mechanisms, we will take care of all the normal vaginal deliveries, the cesarean sections. And healthcare for the pregnant and lactating females. Care with dignity is one of the most important. This can be your 3 by 5 star MCQ topic. And grievance readdressal forums. These are the elements in the Suman scheme. Surakshit Matritva, say the word Ashvasan. Topic number 16. Point number 16 is what is PMSMA scheme. What is PMSMA? PMSMA, it is Pradhan Mantri or the Prime Minister Surakshit. It is the Pradhan Mantri or the Prime Minister Surakshit Matritva Abhiyan. Please note, it's not a Surakshit Matritva Ashvasan. It's a Pradhan Mantri Surakshit Matritva Abhiyan. So what do you think is this PMSMA scheme? So if you just remember in one word, very short, crisp, clear words that I want to say that you should embed in your mind, that the PMSMA scheme is not about the healthy mother, the healthy child, or the sick neonate, or the sick child, or the sick mother. It is about screening. It is about screening in ANC. Screening for what? Screening for the high-risk pregnancies. So whenever a female will come to the OPD, we will screen that whether this female is high-risk pregnancies or whether this is a normal pregnancies or what. So the screening of diseases, mind the words, the screening of diseases in ANC is done under the PMSMA. Screening for diseases in childhood, that is done under the RBSK. So whenever a female is going to enter into our OPD, we have tied up with nursing homes. The government will have tied up with nursing homes. They have something called as PMSMA approved or the PMSMA acknowledged nursing homes. So they will conduct a free ANC clinics. Mind the words, they will conduct free ANC clinics on 9th day of every month. 9th day of every month, they are going to conduct free ANC clinics. So once they conduct free ANC clinics, any female who lands up into their OPD who has some high risk pregnancies, it will be given a red color. If there is any other comorbidities like, for example, the female is having hypothyroidism or any thyroid disease or any other abdominal disease, some comorbid conditions or diseases, she will be given a yellow color. The female, the ANC, will be given a yellow color. In case the female lands up with a pregnancy induced hypertension, she will get a blue color. This is what is MCQs for you. All these are MCQs, and in case the female is normal, there is no hypertension, no comorbidity, no high risk pregnancy, in those cases it is a green color. So it is screening of the females by using a free ANC approach in the public and the PMSM acknowledged centers, approved centers. In these centers, 9th of every month, free ANC, dividing the population into various categories. You can talk about the green sticker means no risk factor, red sticker means high risk pregnancy, blue means pregnancy induced hypertension. This can be your potential MCQ, bache. Please remember, put it in your mind. And yellow means any comorbid conditions as diabetes, hypothyroidism, any. So please remember that 9th of every month the female will be going for free ANC, and you can see the logo over here. The logo is Pradhan Mantri Surakshit Matritva Abhiyan, PMSMA. And following this, the point number 17 is the Pradhan Mantri Matru Vandana Yojana MCQ. This is a very new scheme. It was launched in year 2020 to 2021. So this is a relatively newer scheme. You can just imagine that this is what is the newer version or the big daddy of the GSY scheme. But it is not that it is replacing the GSY, okay? So in GSY, what was the objective? We wanted to have more institutional deliveries. How? By giving incentive. You remember 400, 600 to Asha and something around 1,000 rupees to the mother. Under the Pradhan Mantri Matru Vandana Yojana, we are giving 5,000 rupees. That's a huge number. But the clever point, the trick over here is that the female will get 5,000 in 3 installments. The first installment she will get if she does the ANC within 12 weeks. That is early registration if it is there, okay? So if the female does a proper ANCs, the first ANC within 12 weeks, that is known as first registration. The second amount she will get in case she does a institutional delivery. So that means we have ensured early ANC. We have also ensured that there is institutional delivery. That means there is birth immunization, there is records, there is everything. And third installment will be registration of the child is done and there is completion of the first dose. First dose of vaccination, which happens at 6 weeks. So there is completion of the first dose vaccination, the female will get another 2,000. So it's total how many thousands? 5,000 rupees. Please note, this is apart from the GSY incentive. Don't think that it replaces the GSY. So GSY is there. So total 1,000 for GSY and 5,000 from here, the female can get 6,000 rupees. And this is, please note, it is applicable only for the first child in the family. It is applicable only for the first child in the family. I hope you remember in GSY, in the low performing states, it was for all the females. In high performing states, it was only for the BPL families. But this Matru Vandana Yojana, it is not irrespective of the APL above poverty line or the below poverty line. It is for all females and but for the first child. So it is a centrally sponsored scheme, incentive based service acceptance scheme. That is your scheme number 17 under the RMNCH Plus A program. Let us move ahead to scheme number 18. The scheme number 18 is the Lakshya program. Lakshya stands for Labor Room Quality Improvement Initiative. So it's a quality program. It's about the increase in the quality. What do you mean by the labor room quality? That means there should be good services. There should be good devices over there. There should be good instruments. What do you mean by good instruments? Good quality instruments which are sterilized and sanitized. So it should be a hygienic delivery. So that is what is Lakshya guidelines. So Lakshya guidelines is for delivery huts. Lakshya guidelines will be for sub-centers, PHCs, any delivery point in India. We are going to talk about the Lakshya guideline. That was your point number 18 that is Lakshya guideline. You can see all the logos over here all together. Can you see the Lakshya logo? Please remember, Lakshya is for labor room quality. This is written in Hindi. All those who understand Hindi, well to go, and all those who do not understand, it's a Pradhan Mantri, that is Prime Minister, Matru Vandana Yojana. You can realize, you can see that the logo carries a mother with the child. Please note, it is money given in installments. It is 1,000 initially, then at the time of delivery, then at the time of first dose of vaccination of the child. This is the PMSMS scheme. This is the hands of the nursing care clinic, and on 9th of every month there will be free ANC to do what? To do the screening of disease. And this we have already talked. It's the MA program. MA stands for the Mother's Absolute Affection. MA stands for Mother's Absolute Affection. Mother's Absolute Affection, it is to promote the breastfeeding guidelines. Point number 19. That is the Nutritional Rehabilitation Center. We did in the preventive pediatrics topic about the growth and development, that what is the criteria for admission to a nutritional rehabilitation center. Please remember, these are 3 criteria. Weight for height, which is less than -3 standard deviation. Mind it, weight for height less than -3 standard deviation. If the mid upper arm circumference is less than 11.5 centimeters, and if there is bilateral pedal edema, this is the criteria to be called as a SAM child. SAM stands for severe acute malnutrition. And I hope you remember, in the nutritional rehabilitation centers, we were giving a starter diet and a catch-up diet. The starter diet is what is F75 diet, and a catch-up diet is what is a F100 diet. What is 100? It means the calories. F75, 75 kilocals. F100, 100 kilocals. So that is your point number 19 about the Nutritional Rehabilitation Center, discussed in detail in the video lecture in Preventive Pediatrics. Please make sure that if you have not watched that, please watch the Preventive Pediatrics, because we have discussed NRC over there in detail. This says just some of the points. Point number 20, I've just gathered. It's not going to come in your exam because these are some of the state-based schemes. It is not applicable across India, and most of these schemes have been merged together with the Matru Vandana Yojana and with the Suman scheme. So what is Vande Mataram scheme? It is, everything is to promote, to give good quality mother care services, good quality obstetrics. So that's the reason it's merged with the Suman scheme. So Vande Mataram scheme was launched in Delhi and Haryana and in many northern states. Yashoda scheme is from Telangana, Andhra Pradesh. Mamta scheme was started in Gujarat, Rajasthan. They started the Mamta scheme. So these are state-based schemes. They are not applicable across country. You don't need to memorize them. Just remember that this is to promote the better obstetric care. The main was to promote better obstetric care, and they all almost have been merged together with the Suman scheme. Point number 21 has been already discussed in the chapter on preventive obs regarding the Anemia Mukt Bharat. This is a 5x5 star MCQ topic. So make sure that you study Anemia Mukt Bharat from that video in preventive obstetrics. So that was regarding the 21 schemes that you need to know for your exams. These schemes have been discussed in detail in various lectures, and these are the schemes. This is a 3x5 star MCQ topic. If you don't attempt these questions, these are problems from the student side, I would say, because we have tried to tell you almost everything which is required for your MCQ exams. Your duty is to learn it. See, we can always make you see things and visualize things. We can not learn things on your behalf. We can always teach you things, but we cannot. The war has to be fought by you only. You are going to fight the war in the real life. We have already fought our wars. So I can only teach you how to fight, but the fighting has to be done by you. You only will have to revise. You will have to remember these. So now comes to the next topic, that is the organization of the mother and child health care. So now you have seen what is the target. You know what we want to achieve. You know what are the strategies we have devised to achieve. How do you think we are implementing them? So if you talk about the implementation, there is something called as a delays model. Why do you think that a female will die of hemorrhage? Why doesn't she go to a doctor when she gets hemorrhage after delivery? Why do you think that the female is lying at home? There are social reasons and medical reasons for this. The first reason is there are the 3 delays. This can be asked in your exam, but there are the 3 fundas of delay, 3 concepts of delays. The first delay is that the people will keep on thinking, do I really need care? because the bleeding will not start like boop, it starts. It is a slow insidious onset and then it increases in intensity. So the problem is that people will think that probably it is going to be okay, that there is a delay in seeking care. Delay in deciding that whether you want medical care, yes or no, that is the first inhibition in people. Once they decide that I think I should need a doctor right now, once they decide, then there is a problem in identifying whether you want to go to Dr. A or Dr. B or you want to go to a Sarkari hospital or a government hospital. So then you identify and reach to the medical facility. And the problem is about the reaching also, because the bus is going to come next day morning. The bus is not going to come today night, or the auto wala is not there, or the taxis are not available. We are not talking of me and you who are the elite 2-3% of the society. We are talking of the 97% of the rural India, where there are areas where the bus will come only once in 48 hours in villages. There are tribal areas, there are Naxalite areas, there are forest areas, there are hill areas. There are so many problems in India. So there is a problem about the identifying and reaching the medical facility. So that is your delay number 2. Once you even reach the health facility, then the doctor is not equipped to treat the female in India or the child in India. So there is a problem with the adequate treatment and appropriate treatment. So these are the 3 delays of model. First is the delay in seeking care. The second is the delay in reaching or deciding about the health facility. And third understanding of the third concept is about the delay in adequate and appropriate treatment. I hope you understand. Based on this understanding, now we have organized the MCH care in India. We have a level 1 center, level 2 center and a level 3 center. Common sense, the level 3 centers, these are the most specialized centers, and the level 1 are what are the basic centers that we have in India. Level 1 centers are nothing but, they are very simple. They are the sub-centers. All the sub-centers will be level 1 centers. Sub-center, which one? Sub-center A or sub-center B? Remember the sub-center B, common sense, where the births are taking place. You remember sub-center A was not they were without the health facility for taking births. Please watch the chapter where we have discussed about the healthcare system in India. So the sub-center A is one where the births are absent. Okay, remember that way. Subcenter A is no birth facility. Subcenter B are the centers which have the birth facilities. So common sense, the subcenter B we are talking, and some of the PHCs which are non-24/7 PHCs. That is, they are not very, very functional PHCs. So these are our level 1 centers. Level 2 centers are all the PHCs, all other remaining PHCs, the CHCs, the non-FRU. FRU has to be 24/7, right? Non-FRU, CHCs and things like these are level 2. And the highest level we call them as first referral units, the district hospitals. These all are the sub-district hospitals. These all are the level 3 facilities. So what is the function of them? Beta, in level 1 facility, we will take care of only normal vaginal deliveries. That's what we can take care of. And we can have a basic newborn care corner, plus we can have a newborn stabilization unit in the PHC level only. That is only available at the PHC level. Then at level 2 centers, we will have slightly better services. We can handle any kind of delivery. We can handle the normal vaginal deliveries and we can handle the cesarean or the high-risk deliveries. Plus there is availability of the basic emergency obstetric neonatal care. You remember basic emergency, that is the availability of FRU centers and things like these. So there is advanced newborn resuscitation kits, the newborn stabilization units are there. Even the children who are very sick, they can be taken care of, sick children. And even with females with hepatitis B or HIV females, they can be taken care in level B centers or level 2 centers. In the highest level centers, of course, anything can be handled. We are talking about comprehensive emergency obstetric neonatal care, about all the schemes are available, about complicated deliveries can be taken care. Complicated deliveries, the referral systems will be working here. That is what is the first referral unit, right? So SNCUs will be available. We can take care of any type of the child. I hope you can understand. You can just amalgamate all the 21 schemes now under these 3 categories. You can have level 1 centers, level 2 centers, and the level 3 centers. So based on these, the MCQs may be asked that what is the criteria, what is the beds, what is the criteria, and what is the human rate. This could be a 3/5-star MCQ topic. So how many beds are available in a level 1 center? We already discussed either there could be 2 beds or it could be PHC 4 to 6 beds. So from 2 to 6 beds, it's not 2 by 6 bed, it is 2 to 6 beds will be available in level 1 center. In the level 2 centers, it is 6 to 30 beds. In PHC, you remember 30 beds were there. And in level 3, it will be usually more than 30. It could be up till 80 or 100 beds. So what is the criteria? When will you call a level 1 center, level 2 center and a level 3 center? Level 1 center is when there is more than 3 normal vaginal deliveries a month. If the center is capable of conducting at least 3 deliveries, that is at least a level 1 center. Level 2 centers will be, of course, common sense, more than 3, but they will be more than 10 deliveries a month. So how many days are there in a month? 30 days. Out of 30 days, at least 10 deliveries should happen. So like 1 delivery or 2 deliveries per week should be there. It is more than 10 deliveries, any type of delivery per month, because in this level 2 centers there are the CHCs also. Okay, so any type of deliveries at least more than 2 per week or more than 10 deliveries a month. If we are taking the same denominator, take it as month only, it is easy for you to remember. And for level 3 centers, we will classify the level 3 if there are more than 20 deliveries per month are happening. And they are all like different types of deliveries, complicated deliveries and all that. So more than 20 deliveries will be happening per month. That may be called as a level 3 centers. So what is the staff common sense? There's nothing to remember or understand. In the level 1 center, there has to be minimum 2 ANM and other stuff. Like if we are talking of a PHC, there will be a medical officer and all that stuff. In level 2 centers, it is common sense. If it is a PHC, there will be 1 or 2 medical officers. There will be staff nurses, LTs and other stuff. In case it is CHCs, there will be other people also. We have already discussed these topics when we were discussing the health systems in India. It is the same funda which is being carried over here right now again. And the level 3 is we have when the specialists are there, because we are talking about the CHCs, right? You have the obstetrician, gynecologist. Just to revise over here, just to have a cross connection between the videos, can you tell me please that how many specialists will be there in a CHC? How many? Please remember, it is medicine, surgery, gynae, peds, plus radio, plus anesthesia. How many people we are seeing? We are seeing 6 people. 6 specialists are there in the CHC. Do you remember that? So it's the same funda that we are talking again. So there will be a medical officer. There can be like obs and gynae, anesthesiologist, pediatrician and other staff from CHCs. So I don't think human resource could be a brainer. The question would be either on the beds or the criteria about the level 1, level 2 and level 3. Based on this understanding, now the country is ready to take care about the MCH indicators. So now there are a couple of many indicators. We can talk about mortality indicators, that what is the under 5 mortality rate, infant mortality rate, perinatal mortality rate, neonatal mortality rate, early neonatal mortality rate, stillbirth rate and all that. We can also talk about the fertility rates. You remember in demography we talked about the total fertility rate, reproduction rates. Third is indicator regarding the nutrition, that is the number of children who are weighing less than 2.5, under nutrition rates. Okay. And then you have the gender, cross-cutting, diarrhea rates, pneumonia rates, service delivery. Please note in service delivery rates will be number of females who received 4 ANCs during their pregnancies, number of people who got delivery by the skilled birth attendants, number of females who got ANM or ASHA workers to their homes and things like these. These are service delivery indicators. So based on these indicators, so how many you see? We see 1, 2, 3, 4, 5, 6, 7, 8. 8 MCH indicators. Out of these 8 MCH indicators, we have made a scoring card like this, what you see on the screen. The scoring card is interesting now. The first 3 indicators, that is the nutrition indicator, the fertility indicator, undernutrition. Okay, it's not nutrition, actually it's undernutrition. So the fertility indicator, the undernutrition and the mortality, they should be more than the national average or less. Death should be less, undernutrition should be less. So anytime if your target in the state, these are state level divisions, state and district level divisions. So that's how you define the country into low performing states and high performing states. So if the indicator for deaths, nutrition and fertility is less than 20%, or it is between 20 plus and minus of the national average, or it is more than the 20%. So then your district or state will be state specifically. Then your state is categorized into green category, yellow category and red category. So just mind it that the mother and child health scorecards are there, in which we take that if the first 3 indicators, that is the deaths, the fertilities and the nutrition, if they are less than 20% of the national average, lesser than the 20% of the national average, that will be a green zone. But when is a green zone of the other indicators? Other indicators like gender, diarrheas or pneumonias. So oral rehydration therapy in fluids and care seeking for ARI. If the indicator is more than 20% of the national average, that is taken as a green category. So maybe somebody may ask you about these scorecards, may not be, but at least you should know that these are the indicators we are taking into account. We are taking into account the mortality, fertility, nutrition, gender, cross-cutting. Cross-cutting means about the immunization. So you are talking about the immunization rates, diarrhea, pneumonia, and service delivery indicators. Out of these, the first three indicators, they should always be lesser than 20% of the national average. Other indicators, they should be higher than the 20% of the national average. So with that, thank you so much for watching this module on RMNCH plus A. And with that, we even close the chapter or this whole discussion about a demography, family planning program, mother-child health, preventive vows, preventive pediatrics, and the RCH program. Thank you.
Hi guys, please subscribe my channels.